you'll be happy with the topic this this week, because we're going to talk about tubular interstitial and acute tubular necrosis. احنا بنكون في ال tubular interstitial compartment. احنا طلعنا من ال glomerular compartment and vascular compartment. There's a lot of على قولتهم surgical pathology in this, so you guys will be happy. إنزين في الكورتكس الtubules they have to be back to back with very little interstitium بيناتهم. Okay. طبعا إذا تتذكرون الليكتشر الثاني مالت البيسكس اللي احنا تحكينا عنها, we were saying إن how do we know إن احنا مثلا do we have edema, هل يكون عندنا fibrosis. إذا كان عندنا fibrosis بيكون طبعا we look at the different stains, نطالع الترايكروم, بيصير عندنا واجد blue. And on the PAS ممكن يكون عندنا thickening of the tubular basement membrane, بيكون عندنا يعني مساحة متوسعة بين في الكورتكس, زي نقطة ميدولا في الكورتكس بين التوبيولز. And قلنا إن البروكسيمال tubules بيكون عندهم brush border, لأن كانت تتذكرون في الفيزيولوجي شوفوا هني عندنا brush border, we can see it will be more evident على ال PAS. لأن كانت تتذكرون في الفيزيولوجي ال resorption of the electrolytes and يعني ال nutrients happens في ال proximal tubules. فلازم يكون عندهم هذين kind of like these fringes اللي they work on reabsorption. Okay. This is how it should look like في الكورتكس. إن إحنا عندنا الجلوميرولس وحوالينها أصدقائها التوبيولز, إنزين, and they are back to back with very minimum space اللي هو مال الانتستيشال compartment. Interstitial compartment طبعا هو supportive and it has the peritubular capillaries. ليش اسمها peritubular capillaries؟ لأنهم capillaries صغنونين slit like and they are between الtubules. يعني هذا بين tubule بتشوفون peritubular capillary هنا. الimportance ماله بيكون أوضح لما نروح في transplanted kidney. إنزين خلني أراويكم هذه الكلمة هني, interstitial fibrosis and tubular atrophy. Okay, short مالتها الابريفيشن IFTA. Okay, so we will be talking how bad is the IFTA. لما احنا نقول IFTA معناته we're talking about the interstitial fibrosis and tubular atrophy. طبعا it's mild, moderate and severe. Mild اللي هو less than 0 to 25 and moderate is 25 to 75% and severe is more than 75. Loss of tubules or the presence of fibrosis. Okay. But this is how it should look like normally in the interstitial compartment, highlighted very very thinly بالميسن trichrome, ما عندنا مساحات زرقاء واجد. Okay, بس هني نشوف إن there is a sea of blue. Okay, this is severe fibrosis, interstitial fibrosis هني, because we have a sea of blue يعني distancing هذين الtubules عن بعضهم البعض. How do we know that this is fibrosis rather than it being مثلا edema؟ أولاً بنشوف إنه بيكون عندنا نفس يعني layering and it will be dark blue. إذا كان في edema it will be very light blue كلش يعني it will be kind of like almost whitish blue. and إذا كانت fibrosis بيكون associated وياه على ال PAS tubular basement membrane thickening. اوكي زي ما نشوف هنا يعني you can see هذا هناك thickening around the tubular basement membrane. هذا ما بيصير لو هذا this was edema. If this was edema ما بيكون عندنا وقت انه يكون عندنا fibrosis around the tubular basement membrane, so we're not going to have that. All right, and this is what يعني how thin يعني كأنه بس خط واحد كنا راسمينه, they're just highlighting a tubular basement membrane على ال PAS. بينما إذا كان عندنا atrophy of the tubules بيكون عندنا thickening of the tubular basement membrane. يعني كنا أحد قاعد يعني يبني عليها, عارف شلون؟ they're like layering. these two الفايبروسز اللي يبين إلينا على الترايكروم in the interstitial compartment, okay, and the atrophy of the tubules, these two are called IFTA, interstitial fibrosis, tubular atrophy. وزي ما قلنا it has grades اللي هو mild, moderate, severe. All right, إنزين. Just going through very quickly على شو اسمه المايكرواناتومي. طبعا هذا النفرون مالنا, and over here we have the glomerulus, انزين والبومنز كابسول, وبعدين عندنا proximal convolution و it dips down من الكورتكس تروح إلى الميدولا, and it gives us the loop of Henle ويا ال thin segment وال thick segment, وبعدين عندنا distal convolution. ال proximal convolution هذه اللي هي اللي بتعطينا ال proximal tubules, distal convolution هذه اللي بتعطينا distal tubules, okay? And ال thin with thick loops of Henle, to be honest, يعني we will see them في ال outer cortex اللي هو على شو اسمه juxtamedullary area, and يعني how بتكون ال epithelial cells في ال thin loop of Henle يعني almost kind of like flattened. والثيك بتكون kind of like columnar, and they will lack a brush border. الcortex is where we kind of like زي ما قلت لكم we gauge الإفتا, يعني we don't gauge الإفتا in the medulla, لأن الميدولا already بيكون عندنا فيها fibrosis. We actually gauge الإفتا in the cortex, and we look at both the proximal tubules and the distal tubules. يعني this is silver, بس يعني on PAS you will have a brush border حق the proximal tubules, and the distal tubules they will lack the brush borders, and the cells are going to be slightly smaller, مو flat ولكن بيكونون يعني slightly يعني lower in height. Then they're not going to be as with abundant cytoplasm ويا الفرنجز اللي بنشوفها on the surface على ال PAS. collecting ducts طبعا بيكونون more kind of like cuboidal cells, and هني احنا we are talking about the outer medulla over here. When we talk about tubular interstitial nephritis, we're talking about inflammation that يعني affects predominantly the interstitial compartment في الكدني, and not the tubules. All right, and يعني there are several diseases that affects the tubular interstitial compartment. Most commonly in reaction to drugs. زين, خصوصا يعني مثلا يجي لكم history and there was يعني a patient, and this patient is kind of like يمكن شوية elder and taking multiple medications, and غيروا له المedication مالته. They started him on a new medication, and since they started him on this medication صار عنده oliguria, and they have صار عنده acute renal failure, وشافوا الكرياتين مالته shooting high انزين, and اليوريا مالته shooting high, and he's not producing urine or producing very little urine. and إذا سووا له البايبسي بيشوفون إن الجلوميرولاي حلوين ما فيهم شيء, البلاد فيسلز ما فيهم شيء, إنزين الاي اف ماله absolutely normal, there is nothing to worry about there. But what we have is basically collection of a lymphoplasmacytic inflammation plus minus some eosinophils. I know in the books يقولون إن ويا hypersensitivity tubular interstitial nephritis, especially related to drugs, we should have eosinophils, and maybe يعني the exam question يدج لكم هذا MCQ قال لكم في eosinophils, على طول think about drug reaction hypersensitivity to tubular interstitial nephritis, but not necessarily. And then basically we will see lots of يعني heavy lymphoplasmacytic infiltrate. ممكن بعد يكون عندنا granulomatous tubular interstitial nephritis for all the different reasons of granulomatous tubular interstitial nephritis. يعني ممكن تكون sarcoidosis, ممكن تكون xanthogranulomatosis, ممكن تكون tuberculosis, okay, any of those. Rarely ممكن يصير عندنا ملاكوبليكيا اللي هي as you know, as you guys know, ملاكوبليكيا تصير أزيد شيء في البلادر, okay, and this is due to inability of the histiocytes or macrophages to digest شو اسمه البكتيريا, and يصير عندنا الميكيليز Guttman bodies, لأن there is a defect in the ability of the macrophage to digest the bacteria. So وكلكم طبعا حافظين إن إحنا we will do vancosa if we are suspecting الجفن الميكيليز Guttman bodies and we are worried about malakoplakia, بنسوي الفانكوسا و it will be positive حق في الميكيليز Guttman. The thing is يعني what is important to note here إن malakoplakia is not that common in the kidney, but it can happen. Acute pyelonephritis. Acute pyelonephritis اللي هو basically due to يعني inflammation, infection في lower urinary tract that is ascending, and ascending urinary tract infection ممكن إنه يسبب إلينا and there is a spillage of the neutrophils, and this will be also associated with ATN or acute tubular necrosis. يعني the preference actually is to call it acute tubular injury, لأنه مو دائما يكون عندنا necrosis. We will have injury, but we will not necessarily have necrosis. The thing is to point هني إن acute pyelonephritis, if it's left for a very long time and it wasn't treated, وكان عندنا vesicoureteric reflux, and يعني it became chronic for any reason, مثلا posterior urethral stricture, أو إذا كان عندنا if we had neurogenic bladder, whatever is the reason of a chronic repeated lower urinary tract infection that is not being treated وصار عندنا ascending ويا reflux over the long term ممكن يسبب لنا chronic pyelonephritis. And then and with that we don't have so many neutrophils as we would have in acute pyelonephritis. Predominantly بيكون عندنا tubular atrophy وبيكون عندنا lymphoplasmacytic infiltrate and what is known as thyroidization. كان تذكرون we talked about it once. Thyroidization of the tubules and يصير لهم simplification. They يصيرون cells very flat. They becomes very simplified and يصير شكلهم زي الثايرويد. Okay. All right. إنزين. الحين we will go through some of the important examples and أراويكم صور. إذا كان عندنا acute bladder infection and it is ascending. Okay, for any reason ساعات ممكن إنه يعني هذا البيشنت عنده UTI وبعد عنده benign prostatic hyperplasia for instance أو زي ما قلنا posterior urethra إنزين and يصير عندنا ascending infection. فإذا كانت involving pelvic calyceal system يصير اسمه acute pyelitis, and if it is spilling over into the renal parenchyma يصير اسمه acute pyelonephritis. إنزين how do we know إن إحنا we are dealing with acute pyelonephritis؟ بيكون عندنا الجلوميرuli usually they are spared. زين الجلوميرuli ما فيهم شيء and IF مالنا absolutely normal, but we have lots and lots of neutrophils in the interstitial compartment. عندنا edema, ممكن يكون عندنا neutrophilic casts داخل التوبيول نفسها. بعدين احنا لما نتحكي عن transplant, this is very important. زين لما نتحكي عن transplant, it will be important to differentiate between are we dealing with pyelonephritis or are we dealing with يعني tubulitis. زين and how do we make a difference؟ نذكروا ان هذا جاي ascending, جاي من تحت لفوق. okay فصاعد it involves tubules من داخل and spilling over into the outside. بينما if it was tubulitis زين بيكون انه جاي من الrenal parenchyma into the tubule. okay في pyelonephritis it is involving lumina of the tubules. بيكون عندنا neutrophil casts and بيكون عندنا lots of neutrophils. alright. إنزين هذا chronic pyelonephritis بيكون عندنا scarring into إنزين بيكون عندنا scarring on the surface of the kidney. إنزين broad based scars. بيكون عندنا نوع granular kind of like appearance على الكبسول of the kidney. ممكن تكون if it is subacute ممكن يكون عندنا congestion and edema into the capsule of the kidney. right. okay. oops. إنزين chronic pyelonephritis, like I told you guys, it can happen via vesicoureteric reflux. ممكن يكون with chronic staghorn calculi. Staghorn calculi, as you know, mostly they are due to ممكن يكون E. coli or Pseudomonas, and they are long-standing, obstructing the pelvic calyceal system. إنزين يسببون إلينا persistent inflammation and infection with loss of the renal parenchyma in terms إنه يعني إنه يصير عندنا chronic changes within the tubular compartment. الجلوميرولاي ما فيهم شيء, they're absolutely fine, they're normal, لكن بيصير عندنا deterioration في renal function because of the loss of the tubular interstitial compartment. ويصير عندنا chronic effect حق الtubules اللي هو يصير عندنا thyroidization, simplification of the epithelial cells, and they look just like a thyroid. Again, this is just a larger picture for the thyroidization. إنزين تحكينا إحنا بعد يعني more than one occasion about the difference between thyroidization and endocrinization. Endocrinization يصير شكلها زي الأدرينال. And this is due to ischemia, يعني renal artery stenosis, any form of ischemia ممكن إن هي يعني تموت يعني التوبيولز مسكينة وهي واقفة, يعني just like يقطعون عنها الإمداد and shrinks and shrinks and shrinks and shrinks and it becomes بشكلها يعني very shrunken, just like the adrenal. So we can actually tell يعني إذا كان عندنا thyroidization most likely الإفتهني is because of chronic pyelonephritis. إذا كان عندنا endocrinization most likely it is because of due to ischemia. إذا كان عندنا this form of interstitial fibrosis and tubular atrophy and just يعني series of fibrosis, this is less specific. إحنا we can't really tell why we have IFTA. It might be because of vascular disease, ممكن يكون because of hypertension, or it might be due to diabetes, أو ممكن تكون due to lupus, أو ممكن تكون due to prolonged glomerular disease زي IgA for instance. Okay, so we can't really tell يعني with interstitial fibrosis and tubular atrophy in this picture we can't really pinpoint it to an etiology. Okay. Right. Xanthal granulomatous pyelonephritis, طبعاً I'm sure you guys are familiar with this from your surgical pathology. هي عبارة عن kind of like vague granulomas ويا foamy macrophages ويا lymphocytes with some plasma cells, and again this is due to a prolonged untreated infection, mostly due to again E. coli and Pseudomonas, and maybe associated with Staghorn. Basically you just يعني see sheets of foamy macrophages, histiocytes ممكن إنهم يسبب يعني we might have some granulomas. Very rarely الجرانيلوماز ممكن يكونون فيهم necrosis. أهم شيء لكن إنه ما يكون caseating necrosis, لأن إذا كان caseating necrosis you'll be worried about tuberculosis. يعني ساعات إنه ما عندكم foamy component is not a lot, and it's more kind of like a little bit of foamy cells and predominantly some يعني lots of granulomas. Granulomas تضغي. If you see in foamy cells predominantly with few granulomas, is easy. This is easy. It's called xanthal granulomatous nephritis. بس إذا الfoamy component كان قليل and الgranulomas كانوا أزيد and they might have necrosis, you might be worried and انتونا you're dealing with tuberculosis. طبعا in this instance you will have to do الستينز شو اسمه you can do Grocott حق الفنجل, you can do بعد الزين نيلسون اوكي حق الاسيد فوسفاسيلاي. رايت تحكينا عن مالاكوبليكيا و يعني ويا distinctive Michaelis-Gutman bodies مالتها, and you will do Vancosa and they will be highlighted. Acute hypersensitivity tubular interstitial nephritis اللي قلنا إنه يعني it happens with drugs, and drugs اللي ممكن تسبب إلينا tubular interstitial nephritis. There is a huge list. You can look مثلا NSAIDs مذكورين في الكتب. NSAIDs ممكن non-steroidal anti-inflammatory drugs ممكن يسببون إلينا both interstitial nephritis as well as acute tubular injury, يعني both of them. مثلا ال PPIs الميبرازول اوكي ممكن يعني I'm not saying ان everybody who gets PPI will have interstitial nephritis, لا بس يعني it's one of the side effects مالت ال PPIs اللي ممكن ان الواحد يصيده interstitial nephritis. So there's a huge list of drugs that can give us hypersensitivity reaction to tubular interstitial nephritis. وجود eosinophils يساعد, but it is not necessary for the diagnosis. إنزين خلينا نشوف we're getting more okay, some antibiotics صح okay. Yes, absolutely. Yeah, some antibiotics نفس الفانكومايسين ممكن يسببون لنا الفانكومايسين يسبب لنا ATI أزيد, بس أعتقد off the top of my head I cannot remember the list of antibiotics that can give us tubular interstitial inflammation, but you can have that. إذا كان عندنا granulomatous inflammation يعني polyformed granulomas ويا few giant cells, think predominantly in this is due to drugs rather than you thinking in this is due to sarcoidosis or infection. Rule out, طالعوا list of drugs that the patient is on and make sure that this is not due to drugs. The other thing قبل لا احنا we move out من هذا Sjogren's تعرفين Sjogren's disease. Sjogren's disease ممكن يسبب إلينا شو اسمه tubular interstitial nephritis. فمثلا إذا احنا يعني البيشنت معروف إنه عنده Sjogren's إنزين وشفتون إنه عنده lymphoplasmacytic infiltrate, think of Sjogren's, guys. The other thing ضعيف sorry اوكي كان السلايدات الاولى اللي بعد الفايل بعد الفايبر بس okay. I'll see what I can do, guys. I'll see what can be done. Anyways, don't worry. احنا كل شيء قاعد ينعاد. Everything is being repeated over and over again. إنزين we were talking about Sjogren's. The other thing إن أنا بقول لكم إياه إن مو كل يعني lymphocytic infiltrate we have lymphoplasmacytic infiltrate we have is a tubular interstitial compartment. Sometimes what we are dealing with is ممكن يكون ليمفوما. ترى الليمفوما ممكن تكون in the kidney, and I've seen lots of cases of CLL in the kidney. شو اسمه I've seen cases of حتى diffuse large B cell lymphoma in the kidney. فإذا شفتون إنه هي قاعدة forming aggregates okay rather than يعني diffuse infiltrate forming aggregates وصارت كذي يعني tight clusters and قطوا عليها CD20 CD3 and have a look زين. وبعدين شفتون CD20 أزيد سووا الBC panel and B cell panel and see how it goes from there. So يعني you have to deal with it as you are dealing with a normal surgical pathology specimen. Okay. إذا كان عندنا السمول naked granulomas and ما فيهم necrosis and they are very tight and they're very small, then think sarcoidosis, sarcoidosis, sarcoidosis. And sarcoidosis is quite common in the kidney, and you can suggest that. All right. الشيء الثاني اللي احنا نفكر فيه and actually it's kind of like it's not a very new entity لكن يعني it was first described actually in 1961 لكن دخلوها I think في into the list of diseases I think in 2001 and اللي يعني it was very fashionable يعني it was a very fashionable disease. I remember when I was in training يعني وكان في واجد papers about it and then قسموها ل class 1 and class 2 and then predominantly they were talking about it in the pancreas and in the liver. And then الحين we know in one of the organs that it might affect it's a systemic disease, as you guys know, and one of the organs that it might affect is the kidney as well. Okay, in the kidney تقريبا similar features بيكون عندنا renal interstitial lymphoplasmacytic infiltration، لكن الباثوجنومونيك feature مالته انه يكون عندنا stereoform fibrosis and probably you remember what stereoform looks like من lectures مالت دكتور أحمد اللي هي شكلها زي المروحة and then there's a focal point and then I'll show you pictures and then there is kind of like نوع شو call it يعني نوع ال kind of what's the word أفرع not أفرع it's like wings kind of يعني splaying from it and then it's like there's a focal point and there's like wings splaying from it. Somebody will help me here في هذا دوامات شكرا yes that's the word and then and so you see the yeah متفرعة ومتشعبة yes exactly thank you very much إنزين so بتشوفون إن إحنا عندنا there's a focal point and then we have the هذه الدوامات قاعدة تتفرع زي المروحة منها and then there's fibrosis in between them and cells that are predominantly lymphoplasmacytic and then نقط عليها ونطالع السيرولوجي مال البيشنت بنشوف الليفل مالته مالت IgG4 يطلع الليفل مالته مال IgG4 عالي. How do we diagnose IgG4? IgG4 is a diagnosis that is made according to the ratio of IgG4 to IgG plasma cells. Okay. أولاً نسوي IgG4 stain نطالعه under the microscope and in one HPF high power field, we will have to see more than 10 IgG4 positive cells, and the ratio between the IgG4 and the IgG has to be more than 40%. All right. So إذا كان عندنا هذه all these features, then we make a diagnosis of IgG4 related disease in the kidney, and the patient should respond to steroids. Right, نعطيكم صورة الحين. إنزين so هذه ال IgG4 immunohistochemistry and this is more than 10 cells in one high power field, and then this is what I was talking about إن إحنا عندنا focal point and زي ما قلتون متفرعة يعني مش شعبة إنزين it's like there's a focal point and then it's just like kind of like just splaying from it, it's just يعني splaying. Right. Okay. And على ال EM, we might see immune complex deposits, electron dense deposits في ال tubular basement membrane. This is a tubule, okay? عندنا الابيثelial cell هنا مالت التubule, and on IgG and C3 we might نشوف granular immune complex deposition. Right, نشوف الحين وقفنا خلصنا. What is the difference between phlebitis and vasculitis? Vasculitis, when we're talking about vasculitis, we are يعني talking about ال vessels in general, and يعني we're talking about both the arteries and the veins. The phlebitis is predominantly the veins. And actually يعني thank you for bringing this up, because very rarely, and I had a case, very rarely IgG4 can give us vasculitis. يعني مو تشوفون vasculitis على طول you think about IgG4. If you rule out everything else, and then you see all these pictures that تشوفون lymphoplasmacytic, تشوفون storyform pattern, and you see fibrosis, just throw in an IgG4, look at the percentage. The percentage is 40%, and count the IgG4 positive cells in high power fields, and it's more than 10, then there you go. You can have vasculitis. You can have vasculitis. You can have arthritis with IgG4. Okay, very rarely. Okay, but it can happen. Yeah, this is not the main feature. Right, so الحين احنا نتحكي عن acute tubular injury. Okay, زي ما قلت لكم يعني it's known as acute tubular necrosis, but we don't always have يعني acute tubular necrosis. Necrosis is kind of like sloughing, and a necrosis of the epithelial cells, and they're kind of like being stuffed into the tubules. وعندنا two major categories. عندنا ischemic acute tubular injury اللي هو ممكن يكون due to hemorrhage أو shock أو burn أو dehydration, diarrhea, heart failure. Any of these can give us an acute tubular injury that can give the patient acute renal failure. وساعات ممكن تكون due to nephrotoxic tubular injury due to drugs, إنزين antibiotics, poison, solvents, lithium, gold, whatever. All of these can give us nephrotoxic acute tubular injury. Grossly, how does it look? طبعا يعني this is from an autopsy. إنزين يعني normally acute tubular injury can resolve with support. يعني بدي support ممكن البيشنت يحتاج إلى dialysis might طبعا يسوون إليه support ويا hydration, and they might give the patient what you call it ممكن إنه يحتاج dialysis if it was الكرياتين ماله واجد high، إذا وصل إلى 14 أو 16 يعني وصل إلى 800 أو 1000، إنزين ممكن يسوون له emergency dialysis. وبعدين الكدني شوي شوي تبتدي تنفتح and تبتدي it forms urine again. فيعني prognosis مالتها is not that bad. طبعا يعتمد on the severity of the acute tubular injury. But this is from an autopsy, and what we have is basically pyramids, زين المedula is hyperemic يعني it's very red. والcortex بيكون يعني pale and bulging, kind of like edematous. All right. This is what normal looks like. And then cells, they have abundant cytoplasm, شكلهم happy. They're actually quite يعني fluffy. Everything يعني they look normal. right. بعدين في الانجري يصير عندنا الابيثيليال simplification، شكلهم مضروبين، شكلهم محكوكين، يعني شكلهم الدنيا حاكتنهم مساكين and يعني they had some trauma. إنزين so completely simplified, flattened, loss of the brush border، ما ندري أي واحد distal، ما ندري أي واحد proximal، كلهم مساكين simplified، حالتهم وحدة يعني. ف we are dealing with simplification. Chronic pyelonephritis causes ATM. The chronic pyelonephritis is predominantly, it's a chronic thing, right? And it's affecting, it's fibrosis, so it's predominantly affecting interstitial compartment. Acute pyelonephritis إنزين ممكن إن هي تسبب إلى إن there will be an element of ATI وياها, right? ويا acute pyelonephritis and يعني like we said they kind of like go hand in hand. يعني واحد منهم بيكون يعني there will be interstitial nephritis and there is a small element of acute tubular injury. There will be an acute tubular injury and a small element of interstitial nephritis. So they kind of like go hand in hand. بس ويش الشيء الطاغي هذا اللي يعني it makes you think إنه this is the most predominant etiology or causative etiology. All right. اوكي انزين بعض من الاشياء اللي ممكن ان هي تصير ويانا ويا الاكيوت tubular injury انه ممكن يكون عندنا granular cause. basically هاي الضحايا السيلز اللي ماتوا ممكن ان هم بقية الاشلاء مالتهم تكون داخل اللومن او في التوبيول. ممكن يصير عندنا يعني reactive regenerative changes، يصير عندنا mitosis زين ممكن يكون عندنا mitotic figures. alright. بس هذا not to be confused يا جماعة الخير with a neoplastic process. alright. بيكون يعني this is not very common. Okay, but we can see these features. I'm just telling you, and these features are not pathognomonic of they are not pathognomonic of يعني مثلا a neoplastic process or dysplastic process. You have to put everything into context, right? So if we have a picture of ATN and we have a few mitoses here and there, this is probably just regenerative changes. Right, so high nephrotoxic acute tubular injury يعني basically ذابحين الخلايا مساكين. It's like half of them يعني بيكون أنصاص، يعني نص التوبيول أشلاء مالت epithelial cells، نص التوبيول simplified cells, but overall يعني there will be loss of the epithelial cells and we might have some granular casts, right? Ischemic acute tubular injury predominantly they will just be simplified. ما بيكون عندنا هذه this look اللي هو نص نص still viable نص dead and يعني the granular cast. We just have simplified epithelial layer. And when we talk about this kind of injury, we're talking about sudden loss of يعني blood volume due to dehydration, okay, due to burns, due to blood loss, okay, perfuse hemorrhage. Okay. هذه hydropic changes, again, these are one of the features that can happen with ATN. ممكن يكون عندنا hydropic changes. واحدة من الأشياء اللي ممكن تسبب لنا ATN، احنا لما نتحكي عن ATN نتحكي عن يعني أو ال ATI we are talking about injury to the epithelial cell اللي هي يعني داخل التوبيول، يا أن هي مسكينة مجوعينها ومعطشينها ما عندها بلاد right، يا أن مسممينها معطينها drugs مسممتنها right، يا أن في شيء مزعجنها يعني there is some يعني material that is passing through the kidney و unwanted، مثل شنو؟ مثل المايوغلوبولين كاستس اللي تصير ويا الرhabdomyolysis اوكي for whatever reason يعني sunstroke diffuse seizure اوكي واحد صار له epilepsy وصار عنده seizure and he lost muscle mass اوكي طبعا these cases are suspected يعني المريض جاي وعنده الهيستوري and that's why history is very important. أعيد وأكرر history is very important, more important than surgical pathology. History is important in medical specialities في الليفر في الكدني في السكين they're very 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 important. فيقول لكم مثلا البيشنت عنده epilepsy صار عنده seizure أو إن البيشنت شافوه عنده sunstroke أو شافوه مرمي في البيت dehydrated أوكي فيصير عندنا أو إنه يعني البيت حار مثلا he dropped there and in a very hot يعني ما أدري عنده heater ولا whatever and there is loss of the muscle mass and الكرياتين kinase ماله is through the roof okay وال LDH ماله lactate dehydrogenases بعد through the roof اوكي وسووا إليه هم شاكين إن هذا عنده rhabdomyolysis and they're looking for myoglobin and they're looking for myoglobin casts and we look at the renal biopsy ما في شيء في الجلوميرولاي حلوين IF is fine البلد vessels مالته اوكي بعدين we see kind of like brick red casts داخل التوبيولز and these are not to be mistaken ويا ال RBC casts لأن شلون they're tight and actually they're kind of like brownish maroonish على ال HNE والترايكروم بيكونون bright red اوكي بتشوفونهم bright red على الترايكروم وبتشوفونهم kind of like reddish brownish maroonish على ال HNE وبعدين تسوون الاميونوهيستوكيمستري على المايوغلوبولين ويطلع مولع ف that's it this is your diagnosis we are dealing with myoglobinuria ساعات ممكن إن ويا البال preparation واحد مريض كانوا يبون يسوون إليه فجأة صار عنده acute renal failure post bowel prep زين كانوا يبون يسوون له endoscopy وسووا له bowel prep and صار عنده acute renal failure glomeruli حلوين IF fine blood vessels okay and then we see kind of like calcifications زين within the tubules coarse calcification within the tubules نسوي له von Costa stain so this is phosphate nephrotoxicity because of the bowel prep. Another thing أقول لكم عنه is الأوكزاليت crystals. الأوكزاليت crystals يعني أما بسبب oxalatosis أو بسبب ساعات الجاستريك بايباس تعرفون دول الأوادم اللي يسوون جاستريك بايباس حق السمنة ممكن إنه يصير عندهم oxalatosis أوكي وممكن إنه يصير عندهم deterioration في ال renal function. and نشوف ديلين ال kind of like the crystals and يبينون على ال they polarize and يبينون لنا داخل ال tubules kind of like crystals. ف this can be seen via ال ATI that is related to gastric bypass due to oxalate. السؤال هني صورة الهيدروبيك changes. Okay, صورة الهيدروبيك changes. هني. There you go. إنزين. Basically, it just becomes kind of like a swollen epithelial cell. إنزين, it's like a يعني انتفاخ يعني داخلها ماي. Okay, so acute tubular injury. There's something else بعد I have to mention here. البلازما cell dyscrasias اللي تحكينا عنهم ويا light chain cast nephropathy that we talked about last week وسببت إليكم صدمة عاطفية. They are one of the reasons for AKI. زي ما قلت لكم يعني basically لأن هم they injure epithelial cells لا قاعدين يعني they're kind of like irritating them from the inside. How do we differentiate between مثلا الميلوما casts versus myoglobin? Okay, myoglobinuria. How do we differentiate between these two? مالت المyoglobinuria, what will happen is we will they will be red on trichrome. الميلوما casts أولاً بيكون عندهم نوع giant cell reaction حوالين الكاست. على ال HNE بيكونون fractured, بيكونون فيهم كأنهم مكسرين, تعرفين like قزاز زجاج, and they're like they're fractured, they have fractures within them, and then they have kind of like a cellular reaction around them. They kind of have a giant cell reaction around them. They will not be red on trichrome. They will either be blue or بيكونون kind of like dual kind of like colored. بيكونون يعني بيكونون kind of like polycolored. بيكونون part of them blue, part of them red. يعني they will be multicolored. Let's see if I can in the future أراويكم صور حق الميلوما cast. So that's basically it. So احنا تحكينا اليوم عن tubular interstitial diseases, and we talked about interstitial diseases, and we interstitial nephritis, and we talked about acute tubular injury, and these are the various causative factors. ما بيطلع عن هذا. This is basically what you need to know. And with this we have finished lecture series مالتنا مالت native kidney diseases, and استعدادا من الأسبوع الجاي إن شاء الله we will be going through those concepts again through a case approach.